Hello and welcome to Chapter 17 in Alternate Care Systems. We're talking about cancer registry. We're going to start in the textbook on page 603. We're going to go through the introduction to the setting. The term cancer is applied to more than 100 diseases that are characterized by the uncontrolled growth of cells. The American Cancer Society in 2015 estimated that approximately 1,658,370 new cases of cancer would be diagnosed, and there would be 589,430 deaths from cancer in that year. Cancer is a public health concern because of its impacts on people and on the healthcare system. The Cancer Registry is a surveillance system that systematically collects new diagnosed cancer cases for the purpose of monitoring the disease burden, the quality of care of cancer patients, cancer survival, and disparities. The earliest known example of such surveillance was the General Census of Cancer in London in 1728. The first hospital-based cancer registry in the United States was established at Yale New Haven Hospital in 1926. All right, so let's talk about the different types of registry. So the first one we're talking about is our population-based. It is based on a defined geographic area. It collects data on all newly diagnosed cancer cases in the population of that defined geographic area, which could be a state, a region, or a country. Sources of data for the population-based registry include treatment facilities, including hospitals, ambulatory surgery centers, radiation facilities, physician offices, pathology laboratories, radiology facilities, and other population-based cancer registries and death certificates. The focus of the population-based cancer registry is on public health and epidemiology. The registry is useful for monitoring cancer trends and patterns of cancer in population. Currently, every state in the United States has a statewide cancer registry. Then moving over to 604, we have our hospital-based cancer registry. It collects data for individual hospitals or networks of hospitals on new cancer cases diagnosed and or treated in that hospital or group of hospitals. The focus is on administration and clinical care. The registries are useful in evaluating whether or not patients are receiving standard of care treatment based on the type of cancer and for monitoring cancer outcomes such as survival and recurrence of the disease. And then we've got our special types of registries. So you can have a specialty cancer registry, and these are established for the purpose of collecting data from specific facilities for a particular cancer site or for familial cancers. And so we have some examples here. We have the American College of Surgeons Commission on Cancer's National Cancer Database. It's an outcomes database that can be used to examine cancer treatment trends and survival and for quality improvement in cancer care. It began in 1989 and contains data from more than 1,400 Commission on Cancer approved cancer programs in the United States and Puerto Rico. The database includes approximately 70% of all newly diagnosed cancer cases in the country. Then you have your familial and site-specific cancer registries. These registries serve as research tools and potential sources of education and advocacy for cancer patients. You have a couple of different kinds that you can read about in the text. They include the Central Brain Tumor Registry of the United States, the Breast Cancer Family Registry, the Glenda Radner Familial Ovarian Cancer Registry, and the National Familial Lung Cancer Registry. And you have information on 605 that you can read. All right, let's talk about the different types of professionals working in cancer registry. Many have health information backgrounds. Others have backgrounds in epidemiology, statistical methods, or information technology. Still, others represent various non-traditional backgrounds, but have found roles in the cancer registry. For many of the jobs in the cancer registry, a certified tumor registrar, or a CTR, credential from the National Cancer Registrars Association is required. Those with health information backgrounds are well suited for obtaining this credential and working with the data collected in the cancer registry. We'll talk about the CTR a little later in the chapter as well. All right, moving over to regulatory issues. I'm not going to go into just a lot of detail on this, so be sure to read your regulatory issues. But in the United States, cancer registration is considered to be high-quality public health surveillance system. One of the reasons for this designation is the data standardization. In the late 1980s, when a push to aggregate data across cancer registries occurred, there was a dearth of data standardization across cancer registries of different types. This limited the utility and comparability of the data collected and resulted in a considerable amount of time and money spent just to make data from other hospital cancer registries integrate into central cancer registry systems. Today's standards of data collection allow for comparison of data across cancer registries and for compilation of data on regional and national levels. Requirements for the data elements and timeliness of the data collection, however, vary across the different types of registries based on the state laws and reporting regulations and to what national organizations the registry submits data. Several standard-setting organizations and professional organizations work under the umbrella organization of the North American Association of Central Cancer Registries, or the NAACCR. This organization establishes and maintains uniform data standards for hospital-based and population-based cancer registries. Then we have the Commission on Cancer. It was established by the American College of Surgeons in 1922. The COC developed the first standards of quality multidisciplinary and comprehensive care delivery in the healthcare setting. Comprehensive cancer care delivery in the healthcare setting. The COC continues to provide hospital-based cancer registries with data standards and coding instructions that are updated regularly to meet needs of cancer surveillance in the form of the Ford's Manual, the Facility Oncology Registry Data Standards. Then we have SEER, S-E-E-R, which is the Surveillance, Epidemiology, and End Result Program. It's a population-based cancer registry that funds specific states, metropolitan areas, and native populations for data collection. It began collecting data in 1973 from a limited number of registries and continued to expand the number of registries to cover a greater percentage of different demographics. All right, moving down to the National Cancer Registrars Association. This again is where the CTR credential, or the Certified Tumor Registrar, this credential establishes the standards of knowledge for a cancer registry professional. They began actually certifying in 1983. All right, dropping down to North American Association of Central Cancer Registries. We just talked about the NAACCR. It was established in 1987 and serves as the umbrella organization for central cancer registries, government agencies, professional organizations, and other cancer-related organizations to come together to improve quality and utility of cancer data. The membership of the NAACCR includes groups from the United States and Canada. All right, moving on to the National Program of Cancer Registries over on 609. In 1992, Congress passed the Cancer Registries Amendment Act, authorizing the CDC, or the Center for Disease Control and Prevention, to provide funding to states and territories for collection of cancer data and to establish standards for this data collection process. The CDC established the National Program of Cancer Registries and began providing funds to statewide population-based cancer registries in 1994. The NPCR also established program standards and standards of data quality, timeliness, and completion. All right, moving over to page 611 to get talking about documentation. One of the big things in cancer registry is the abstract. An abstract is a summary record that allows for the systematic collection of information on a cancer patient's experience in a standardized format. Thus, abstracts are the most important documents maintained by the Cancer Registry, and they form the basis for all of the registry operations. A cancer abstract contains several categories of information on the cancer patient and their diagnosis. All right, so first is going to be our patient information, and this should be a review of health records. We've talked about the accession number. This is a 9-digit number assigned to the patient when they're diagnosed with cancer. It's computer generated, and the first 4 digits specify the year, and the last 5 digits specify the order in which the patient was entered into the registry. So following this pattern, the first patient entered in 2016 would be assigned the accession number 2016. That's the first 4 digits for the year 2016. And then they were the first case in 2016, so the last 5 digits would be 00001. 4 zeros and a 1. The patient also is given a sequence number indicating the order of the cancer diagnosis that the patient had in his or her lifetime. Other information in the patient information section include the patient's medical record number, name, social security number, birth date, address at the time of the cancer diagnosis, place of birth, race, Spanish or Hispanic origin, primary payer at the time of diagnosis, any comorbid conditions that the patient may have, and the physicians involved in the cancer care. Then we have our cancer information. This is going to be the information that describes the disease. Data items included are the class of case, which describes the relationship the patient had with the facility reporting the cancer. In addition, the facility that referred the patient to the reporting facility and any facility to which the reporting facility referred the patient are included. Dates included in this section are the date the facility first had contact with the patient for cancer and the date the patient initially was diagnosed with cancer. Cancer-specific information includes the primary site, histology, the behavior, which includes whether it's benign, borderline, in situ, or malignant, the laterality, and the grade or differentiation of the cells. Also included are diagnostic confirmation details about whether the cancer was confirmed by histology or cytology, or if the case was confirmed by clinical means without tissue diagnosis. Then we have the stage of the disease. The stage of the disease at diagnosis consists of fields that describe the size and local extension of the primary tumor, and whether or not regional lymph nodes are involved with cancer, or whether or not distant metastasis was present when the cancer was diagnosed. Stage can be assessed clinically to assist the clinicians in the planning, treatment, and then pathologically to assess the effect of the neoadjuvant therapy or the need for adjuvant therapy. Both stages would be recorded in the hospital cancer registry. Staging data also is useful in population-based cancer registries for assessing screening patterns for cancers with effective screening. All right, moving over to treatment on 613. Hospital-based cancer registries and population-based cancer registries both collect information at the first course of treatment. Hospital cancer registries at Commission on Cancer approved hospitals also collect information on subsequent treatment and palliative care. All right, dropping to outcomes. All cancer registries collect information on the last date of contact with the patient, whether or not they are alive on that date, and if the patient has died, the place of death, cause of death, and whether an autopsy was performed. Hospital cancer registries and Cancer on Commission or Commission on Cancer approved facilities also record information on the patient's current address and phone number and the contact information of the person who would know about the patient over time. Then we have case administration. This includes information on the abstractor and the reporting institution, as well as information on the versions of coding manuals and coding systems used in abstracting the case. Then you have text documentation. The text fields are included in the abstract for the abstractor to justify the codes that are assigned in the abstract. It also summarizes the patient's cancer experience. Then you have suspense case. This is an abbreviated abstract. And before preparing an abstract, the hospital registry must identify the cases to be abstracted. This is done in a suspense system within the registry software. Pathology reports and disease indices are used to identify potential cancer cases for abstracting. And so these documents are used to create the abbreviated abstract, which is called our suspense case. The registrar examines suspense cases to determine if they are reportable and should be abstracted. All right, we're going to move over to revenue generation on 615. Basically, cancer registries are non-revenue generating departments. They're not making money for hospitals, but the data contained in the registry can be used by the hospital administration for marketing and improvement of patient care. And this can impact the bottom line of the hospital's budget. So I'm not going to go through any more in that section, so be sure to read that revenue generation section. And we're going to drop down to coding and classification. And again, if you remember from health records, we're talking about the International Classification of Diseases for Oncology, which is ICD-0. This has our topography codes based on the neoplasm chapter in the ICD-9 morphology codes, based on the Manual of Tumor Nomenclature and Coding. Moving over to, let's go back to this one sentence. The first edition of the ICD-0 manual was published in 1976 after physicians expressed a desire for cancer supplement to ICD-9 that would include morphology. Over on 617, it tells us that the second edition of ICD-0 was published in the 1990s. The topography codes were changed to be based on ICD-10 instead of ICD-9. Widespread use of the second edition in the U.S. began in 1993. In addition, new morphology terms were added to the second edition, and the lymphoma section was expanded. The third edition of the ICD-0 was published in late 2000 and implemented in U.S. registries on January 1, 2003. This edition incorporated the WHO classification of hemopoietic and lymphoid neoplasms. Morphology terms were defined further with new synonyms included in the manual based on terminology used by pathologists. Several neoplasms changed behavior codes from borderline to malignant. And the third edition of the ICD-0 is still in use as of 2014. As far as I know, it's still in use today. All right, then you have SEER, which again, we talked about that a little bit earlier. But yet, in 2007, the SEER Multiple Primary and Histology Coding Rules, developed by a task force of cancer registry professionals and standard-setting organizations, were implemented to guide cancer registries in determining the number of abstracts to prepare for solid tumors and how to assign the appropriate histology code for each primary tumor abstracted. These rules replaced all previous rules that had been used to determine the number of abstracts to complete for solid tumors. All right, we're going to move down to our cancer staging. The stage of the cancer refers to the extent of the disease. Assessing the stage of the disease can assist the physicians in determining the appropriate treatment and in determining the patient's progress or prognosis. The stage of the disease includes the local spread of the tumor, involvement of regional lymph nodes, involvement of distant lymph nodes or tissues, and prognostic factors. The stage of disease can be determined through the information from the physical exam, radiological procedures, endoscopy, surgical procedures, pathology reports, prognosis factors, progress reports, and discharge summary. All right, and you can read about the 3 different staging systems. We have the American Joint Committee for Cancer Staging System, the AJCC. You have the SEER summary stage, and then you have the collaborative staging data collection system. I'm not going to detail any of that, so be sure to read those sections. All right, let's get back to cancer treatment. Cancer treatment is dependent on the type and stage of the cancer diagnosed. Treatments for cancers include surgery, radiation, chemotherapy, hormonal therapy, immunotherapy, and transplant or endocrine procedures. Many patients receive multiple forms of treatment. Treatment can be curative or it can be palliative. Dates are coded when the treatment is initiated and the start date of each treatment modality is used. There are surgery codes for cancer-directed procedures done to the primary site, regional lymph nodes, and distant sites. Radiation codes exist for types of radiation, radiation volume, radiation doses, as well as the date of the treatment ends. Codes for other treatment modalities are not as extensive as those for surgery and radiology. All right, be sure to read through the section coding rules and data elements. I'm not going to cover that section. I'm going to get down to data flow, data and information flow. The hospital-based cancer registry uses several sources of data and information for case finding. The primary source for case finding is the documentation found in pathology reports. Other case finding sources for registries include disease, indices, and discharges, medical and radiation oncology logs, outpatient records, and diagnostic radiology reports. Potential cases identified then are put in the suspense system until a final decision on reportability is made and an abstract is begun. Some hospitals abstract cases concurrently as data become available on the case. Others wait two or more months before abstracting the case. The Commission on Cancer has a rapid quality reporting system for breast and colorectal cases to monitor whether or not patients receive timely treatment according to the National Treatment Guidelines. This system requires concurrent abstracting of breast and colorectal cases for participating hospitals. As cases are completed, edits and quality control procedures are carried out, and the cases are then ready for use. At this point, they're also ready for reporting to the Central Cancer Registry and the National Cancer Database. Sources of data for the population-based registry include hospitals, both those with and without cancer registries, independent pathology laboratories, private clinics, ambulatory surgery centers, freestanding radiation centers, oncology clinics, death certificates, nursing homes, hospices, and out-of-state cancer registries and out-of-state facilities. Population-based cancer registries make as many of these sources electronic as possible. All right, we're going to move over on to data sets over on page 622 at the bottom. A variety of data sets may be used in cancer registry. Data sets produced by cancer registries are constructed based on how the data within the set will be used. Confidential data sets based on standards development by NAACCR are produced by hospital cancer registries and other electronic reporting sources for reporting to population-based cancer registry. Specified data sets without individual identifiers are produced in reporting to the NCBD, NPCR, SEER, and the NAACCR based on the data elements required by each standard setter. All right, we're going to move on to our quality improvement and utilization management. I'm going to cover just a couple of things here. So the Commission on Cancer, SEER, and the NPCR require edits to ensure codes are valid and code combinations made sense. The Commission on Cancer requires quality control plan for cancer registry data, and they set quality measures for patient care. Hospital-based cancer registries at the Commission on Cancer approved hospitals submit data to the National Cancer Database. And the other thing I wanted to pull out is population-based cancer registries provide frequencies, incident rates, and in some cases prevalence rates for cancer in the population they serve. This information is used to develop cancer control programs, monitor the disease burden and how it differs for different groups in the population, map the disease burden, and generate hypotheses for studies to determine causes of cancer and cancer disparities. And then we have our legal and ethical issues. I'm going to let you cover most of this section on your own. But that first paragraph, I just want to bring it out. The data collected and maintained by the Cancer Registry are confidential and subject to numerous laws and ethical considerations. Collection of cancer data by state cancer registries is mandated by state law. Thus, cancer patients do not consent to collection of their cancer information, or in many cases do not even know that it's collected. Confidentiality for the patient and for the reporting facility is essential. All right, and we're going to finish up with the role of the health information professional. So HIM professionals play a key role in cancer registries. Most of the positions in the cancer registry require the CTR credential from the NCRA. Graduates of HIM programs hired by a cancer registry must have earned a C or better in the 2 semesters of human anatomy and physiology and obtain 1 year of experience prior to being eligible for the exam. The exam is only offered 3 times a year, March, June, and September. Alternately, HIM graduates could earn a certificate in cancer registry management or cancer information management from an NCRA accredited certificate program and complete a 160-hour practicum in a CTR staff cancer registry to be eligible for the exam. And that's not necessarily it's not necessary for someone who has an HIM degree already. But there are also NCRA accredited associate degree programs that include the required practicum that will also lead to the eligibility for the CTR exam. Many job functions available in the cancer registry can be fulfilled by HIM professionals, especially those with a CTR credential. These include case finding, abstracting, and coding cancer incident reports, follow-up on patients in the cancer database, quality control of cancer records, record linkage, management, supervision, maintenance of software and other databases, software and database design, development of edit sets, technical support for cancer registries, training, auditing, consolidation of duplicate records at the population-based registry, maintaining documentation for the hospital's Commission on Cancer Approval, data analysis, liaison with researchers who are interested in using cancer registry data, development of cancer registry data, or standards, and geocoding. Cancer registry professionals are the experts on the utility and limitations of the cancer data contained in the registry. They serve as a valuable resource to the hospital's administration in interpreting the information to ensure that the decisions are made based on the cancer data that are most beneficial for the patient and the hospital. So again, be sure to read through the entire chapter. There was a lot of sections that I didn't cover. So again, I want you to make sure that you go through and have a fairly good understanding of these different organizations that affect cancer registry. So again, good luck, happy studying, and again, read through the PowerPoint, read back through your chapter again. This is our last chapter in alternate care systems, so we are right here at the end. So happy reading and happy studying.